How's it going, everyone? Mufara here. Welcome to Heliopolis Radio. We've been fortunate enough today to be joined by Dr. Lyn Yaffe. He's the founder of Emergency Preservation and Resuscitation. In short, it's called EPR. And I'm not going to waste any more time, so I'll extend it to you, Doctor. Tell us about yourself. Tell us about a bit about your educational background, how your journey in medicine has been thus far. And yeah, over to you.
Okay, I'm delighted to be here. It's a pleasure to be here and to talk about EPR technologies. As you say, if you want a little bit of my background, I was raised I was born in England.
Wow.
My father was over in England during World War II and met my mother, but he brought me back to the US and went to school in Baltimore, Maryland. Which is, close to Washington, D.C.
Mm-hmm.
And for undergraduate, I went to Johns Hopkins University.
Wow.
And then I went to the University of Maryland Medical School. And then for postgraduate training, I went to Columbia University and did a residency in pathology.
Wow.
And most of my time I spent in research. I spent a number of years in the United States Navy because I had some obligated service. And during that time, I worked at the Naval Medical Research Institute and also managed a lot of Navy medical research programs. And it was in my later years in the Navy, in about 1995, I started working with Dr. Peter Safar.
Mm-hmm.
And so I knew him from about 1995 to 2003 when he passed away. But Dr. Peter Safar is considered the father of cardiopulmonary resuscitation, which we call, CPR,
mm-hmm.
mouth-to-mouth resuscitation, chest compressions, defibrillation. If someone has a heart attack and they need to be resuscitated, or if you're a trauma victim and resuscitation is tried, CPR. And Peter Safar is considered the father of that. In the early to mid 1950s, he actually invented mouth-to-mouth resuscitation. Prior to that, they had some ineffective ways to fill your lungs, raising your arms, but none of it worked well. And chest compressions actually go back to the early, 1910. But it wasn't really effectively used in any way. But Dr. Safar put chest compressions, organized that together with mouth-to-mouth and defibrillation, which really only got started effectively in the 1950s when Dr. Safar was working on mouth-to-mouth. So he put it all together and wrote the first book called The ABCs of Emergency Medicine in the early to mid 50s. And then once that was seen to be effective, he went around the world talking about CPR. And in the mid 50s, after he did that, the US military adopted CPR as their emergency intervention when the heart stopped. Prior to CPR in the United States, and I'm sure in most of the world, there was no emergency call for an ambulance. In the US today, you dial on your phone 911 and you speak to an operator who will dispatch paramedics, okay? When Dr. Safar, at the University of Pittsburgh at the time, when he invented CPR, there were no paramedics. In fact, Dr. Safar trained the first paramedics. It's an interesting story. He took some African-American orderlies who worked at the University of Pittsburgh Medical Center, and also some other individuals through contacts that he had, and he trained them to be the first paramedics. He designed the vehicle, and he trained them to be the first paramedics, and it was called Freedom House. And when the police in Pittsburgh got a call, because that's all you could do, even if you had a medical emergency, the police would then dispatch Freedom House, a group of paramedics. And they eventually became well known. And his early paramedics, they went to other cities to train more paramedics. And now, of course, across the world, paramedics are everywhere. But all that is owed to Dr. Peter Safar, who died in 2003. Now, that work on CPR was funded by the U.S. Army. And subsequently, during the Vietnam War, as in prior wars, the military said, 80% of the killed in action die from massive hemorrhage. If you're killed from a massive head wound or you're blown into pieces, there's nothing you can do. But 80% of those killed in action actually bleed out rapidly, and there's no time to give them blood or fluid or to even do CPR. So the military asked for ideas, and Dr. Safar, the father of CPR, he said, why don't we do temporary suspended animation? He called it suspended animation, but it's sort of a science fiction term.
I think when most people hear that, they think about someone floating in a tank of liquid and something like that.
Exactly. But what he was referring to was to rapid, profound hypothermia, where if you can't immediately resuscitate someone because they've lost so much blood or you can't control the bleeding, instead of trying to resuscitate them, cool the body down to 10 degrees Celsius. I'll explain how that's done. But you cool the body down to 10 degrees Celsius. At that cold temperature, it's not freezing, it's above freezing, obviously, but at that cold temperature, you have no heartbeat because your heart stops beating if you go below, let's say, 33 degrees Celsius, your heart will stop. So certainly at 10 degrees, you have no heartbeat, you have no breathing, and you actually have no brain waves. So you appear to be clinically dead, but your cells in your body, in your vital organs, your neurons in your brain, they're still alive. They're sort of in a very low metabolic state, sort of even less metabolism is going on than like a bear hibernating. And so experimentally in large animals, Dr. Safar discovered you could keep a large animal like that for 3 hours. So in other words, they appear clinically dead. They're not dying because they still have cellular life at a very low level. So with no heartbeat, no brain waves, no respiration, you don't have to worry about stopping bleeding anymore. You've cooled them down with cold saline, which I'll say more about. But then you've got 3 hours to sort of take them to surgery, do repairs, give them blood, and then rewarm them, and then resuscitate them. So we call it, the cooling phase is called emergency preservation. And then the surgery's done, then the resuscitation is delayed. So at the end of the procedure, you do the resuscitation. And now, this idea, occasionally there are reported cases where a skier is caught in an avalanche. And the skier in the mountains in an avalanche cools down so quickly that their heart stops, their brain waves stop, they're not breathing, their metabolism is low. They're sort of in a temporary emergency preservation, a suspended animation. And if the rescuers can find them, and you're lucky, if they find them quickly, they can then rewarm those individuals and resuscitate.
I've heard stories.
But in the medical literature, there's some reported cases where that's successful. And in those cases, you're talking about a healthy athlete. We're talking about a healthy skier, at least. What we're talking about are traumatized victims, gunshot wounds, automobile accidents, sudden cardiac arrest that can't be resuscitated. So EPR is designed to give a person who cannot be immediately resuscitated one more chance at life, at resuscitation, by putting them in a temporary suspended animation cold state, repairing their injuries, and then resuscitate.
Can I just ask one question though in regards to that? So in terms of just the equipment needed to induce that temperature change you speak of, I was actually wondering what's the cost going in behind it? Because I'm thinking more the frequency. I saw on your website the frequency of heart attacks and cardiac arrests that happen. That means that equipment would have to be readily available across all dispatches. So let's just say, for instance, just developing one unit for one first responder. How much would that cost roughly to kind of get everything set up? Or maybe not even cost-wise, but is
Right.
it yeah.
Yeah, let me just say about that. Obviously, we're not selling products yet. Our clinical trial on human beings, putting them in EPR or suspended animation, is ongoing at Maryland Shock Trauma in Baltimore. And we hope soon to also start it at Cook County Hospital in Chicago. Now, that clinical trial is being funded by the U.S. Army.
Oh, okay. Yes.
And the U.S. Army actually paid for all the research. They don't have a commercial interest. They granted the money, so, you know, the patents are owned, and the company will operate like any other biomedical company.
Yes.
What's required to do this is you have to get access to the arterial system of the body, you know, meaning your arteries, either the aorta or a major peripheral artery, like you could say a carotid artery in the neck, as an example, a femoral artery in the groin. You know, the access point depends on what injury you're dealing with.
Yes,
okay?
yeah, I completely
Obviously,
understand.
you wouldn't do this, as I said, on a gunshot wound in the head unless the person appeared to, you know, be survivable. And so once you identify the artery that you're going to access, you then put in a large catheter, a large tube that is sort of has the diameter of your index finger, okay? You know, much larger than you might put something into a vein. And so now you've got access. And, you know, I'll just say a catheter. We have designs and prototypes for specialized catheters to make this very easy for a paramedic or an emergency room nurse or physician to do. And we use augmented reality and also the assistance of artificial intelligence.
Wow,
as a sort of
incredible.
move now, in order to make access to the catheter, to the artery, using the specialized catheter as easily as possible. Now, catheters can be, that kind of catheter can be anywhere from $1,000 to $2,500, depending on which particular catheter. You know, I hate to say it, in the US, of course, medical products and drugs, they sell based on what the traffic will bear, in a sense, you know. But still, $1,500 to $2,500 is inexpensive for a specialized arterial catheter. Okay, so once the catheter is in, then you've got a system to pump in ice cold saline. How do you put the person in suspended animation? You have to cool the body down. How do you do that rapidly? You pump in liters of ice cold saline. When I say ice cold, I mean 1 to 2 degrees Celsius. So you pump in 20 to 30 to maybe 40 liters, depending on the size of the individual, into that artery, and that will rapidly cool the brain and vital organs. Yes, you're draining blood out of the person as you flush out the blood with cold saline to cool them down. Whatever blood remained in the body, they're cooling down. If it's a trauma victim, they've been bleeding out anyway, so you just flush out that blood faster. If you do this in a sudden cardiac arrest victim who cannot be resuscitated because of some cardiac condition, they're not bleeding. In that case, you also put a catheter into a vein. So as you pump in saline, the blood can come out of the vein. You follow me?
Yeah, because of the clogged arteries, yes.
Okay, so in, let's say, 10 to 12 minutes with a rapid flush of cold saline, you drop the body temperature down to ideally 10 degrees Celsius. And you measure that drop in temperature by putting a thermometer, it's called a tympanic thermistor, a thermometer, in a sense, a temperature monitor, into your ear to measure the temperature behind the tympanic membrane in your ear. That's, you know, that's standard, easy medical practice, because what you're interested in is what's the temperature of the brain. That's the vital organ that you want to cool down fast enough. Your brain is the organ, needs oxygen. and you've got no blood. We're flushing out blood. So the colder you get them, the faster, the less you have to worry about oxygen to the brain. Now, all of this was done on large animals like pigs, and it's very successful. The pigs all do fine. And that's why the human trial has now been started and is ongoing at Maryland Shock Trauma. So the monitoring equipment that you would use to measure the temperature and the flow and the pressure and everything that's happening as you're doing this, that piece of equipment can cost, let's say, $12,000 to $15,000. But we'll have smaller versions of that let's say will be in the neighborhood of 5,000 to 8,000 that a paramedic will have. And, I can only talk about the U.S. that medical centers and emergency paramedic units, they can afford that cost.
That type of cost, yes.
In one sense, you have to measure that against the potential life of the individual. You don't want to say, well, we didn't try to save your son because we didn't buy the equipment. That's not acceptable. And like any other procedure in the U.S. or the world, there's reimbursement. You have health insurance, or the government in the U.S. has Medicaid, or they have ways of reimbursement. So this will spread quickly once it's approved by the United States Food and Drug Administration as a procedure, which will be after the clinical trial, and then we're prepared. So let's say with that equipment, the cold saline, which costs nothing, we have some experimental additives to put in the saline, but for the clinical trial, the FDA, the Food and Drug Administration, only wants to check on cooling. So we've got the catheter, we put it into the arterial system, we use cold saline to cool the patient down. Now they're cold. You take them to the operating room and you repair what injuries the patient has. There can be a whole spectrum of different injuries. If this is on the battlefield, hopefully they'll be able to cool the patient down quickly. A medic will take them to a surgical unit where they can do repairs and then do the delayed resuscitation. In a civilian hospital setting, the ambulance, once you're cooled down, you're usually only 10 or 15 minutes by ambulance or helicopter from a major medical center. You're taken to the trauma unit. You're still cold. They do surgical repairs, okay? And then they close you up. And the last thing they do is they put you on what's called cardiopulmonary bypass. Now, a cardiopulmonary bypass machine is already an approved machine that all medical centers have. People are put on cardiopulmonary bypass when they do difficult cardiac surgery. Sometimes they put you on cardiopulmonary bypass if they're doing brain surgery. So we've now got a cold patient who's been surgically, repairs have been done. Now you put them on bypass and you give them back blood from the blood bank, to match their blood type. And the cardiopulmonary bypass machine starts to rewarm them.
No. Okay.
When the body temperature gets up to, let's say, 33 degrees Celsius, 34, your normal is 37. When you get to 33, your heart will spontaneously start to beat. So in one sense, that's delayed resuscitation. If your heart doesn't spontaneously start at 33, they'll do a defibrillation. They'll put the paddles, you're in the operating room, they'll put the paddle and they'll get your heart started. And then when your heart starts, you'll start breathing as well. If you don't start breathing, they'll put you on a respirator. They may put you on a respirator then just to give you, maximum oxygen. And so now your heart's beating. You may or may not be on a respirator. Usually they want to keep you mildly cold for a day or two. In other words, don't bring you all the way to 37, bring you to like 34, 35, because that sort of mild cooling just helps you recover more. And then hopefully, you're off cardiopulmonary bypass, your heart's beating, you're off a respirator, they stop the mild cooling, you warm up to, now on your own, you warm up to 37, and hopefully whatever your injuries were, you're not going to suffer complications from that. so you're fully recovered.
I just had two questions. Sorry, doctor.
No, that's okay. Go ahead.
Coming back to it, so the main one was you did mention that this technology is also can be utilized by non-medicine personnel. So let's just say if there's an EPR present at a school where someone's had a cardiac arrest and there's a staff member that's trained to probably use the devices that you mentioned. How difficult will it be for someone outside of who doesn't have a background in CPR? How will they know exactly how to operate the equipment, and how will the training work?
Exactly. Yeah. Well, first off, let me say every adult should get certified in CPR.
Yeah.
So you can be an effective bystander. In the US and many countries, they have public defibrillators. At airports, if you notice, they'll have a defibrillator where you can open the window and then use that. Hopefully a bystander is there, and they have these at office buildings too. And a bystander is there who knows CPR, who knows how to use the defibrillator. And the defibrillators now are so sophisticated, with their algorithms, that it doesn't take much to use it. Even if you're never used one before, you follow the instructions. Some of them have audible instructions. Now, doing EPR on a patient that doesn't respond to CPR, you have to have the equipment there. You have to have the cold solution. So the idea would be that you must wait for a paramedic.
Oh.
So while the paramedic is on their way there, hopefully someone is continuing CPR. In other words, as long as good CPR is being done, you're getting blood flow and oxygenation, right? That's what CPR. So CPR could be, if it's being done effectively, CPR can be done for 30 minutes. In a hospital setting, they may do CPR for 40 minutes with repeat defibrillations, before they give up on someone. So out in the real world, not in a hospital setting, you'd have to have someone do CPR at the same time. You call 911 and then you call the paramedics, then you start CPR, or there may be several people there to take turns doing the CPR while the paramedics arrive, within 10 minutes, 15 minutes, and then the paramedics will do CPR for a few minutes. If they can't get the heart started, then they have the equipment, cold solution, the catheters, the portable stuff to do EPR. And, we would require paramedics to be trained in EPR. We're working on training, education, simulation technology to train them. It's sort of like train one, see one. Familiar with the equipment, they'll be able to do it. So, I'm sure the FDA will require some certification for personnel who are going to do EPR, and that would be required around the world. But the procedure, at least initially, maybe in the distant future or not too distant future, it'll be more automated, like CPR is so very automated now. If you buy all of the automated equipment, and with AI, as we hope to utilize, a lot can be done. When you also look at humanoid robots, you can see in the future a CPR, EPR trained humanoid robot.
No. I mean, that is the future we're moving towards. But that brings me into the next question. Was you mentioned the 3 phases. So obviously there's the cooling, there's the operational phase, and there's the reheating. And this is obviously undergoing trials. How successful have you been in terms of the likelihood of survival? Let's just say that transitioning through that process, because obviously the person's clinically dead and you're banking on them coming back after the whole procedure is done. So
I'll only talk about that briefly, because the clinicians that are doing this and the FDA, they don't like to hype.
Okay, no, I completely understand. Yes.
A few years ago, we had a period where we stopped the clinical trial because of the COVID pandemic.
Yes.
Because during the rewarming phase, we use a lot of blood from the blood bank, and during COVID, a lot of blood was used for patients who were put on what's called ECMO, extracorporeal membrane oxygenation, where their COVID was so bad they needed to be on sort of a lung machine, and that required blood. So we had a long period where we didn't do the clinical trial. But early on, before COVID, information got out, and you can look at some of the science magazines. I have links to them, and it's probably mentioned on our website, where they said, oh, a human being has been put in suspended animation, which was true, okay? And so the clinical trial continues. I should say that resuscitating the person, while it's a difficult procedure, for long-term survival is not the issue. In other words, people can get resuscitated with delayed resuscitation with EPR, just like you can be resuscitated with CPR. But in either case, just because you're resuscitated doesn't mean you're going to leave the hospital and survive. Many patients following CPR or ultimately following EPR may have multiple organ problems because of the time it took before the paramedics got there, or what are their series of injuries, you know, without good blood perfusion going on. When you finally restore circulation in blood, you can have what's called reperfusion injury, where free radicals are produced, free oxygen radicals. I won't go into all of the science, and that can cause multiple organ failure. So, you know, not everybody who survives, not everybody who is resuscitated by CPR resumes a fully normal life. And it'll be the same with EPR. In one sense, EPR gives one more chance at survival. And hopefully, as medical care improves, as the ability to be resuscitated quickly improves, you'll have a better chance. But there's no guarantee that, you know, everybody will recover fully. In the US, people who have a sudden cardiac arrest for whatever reason, only 12% of them are resuscitated out of hospital resuscitation by bystanders or paramedics. Only 12% of those people survive. Whether they're fully functional, it's a little less. In the hospital, if you have a cardiac arrest in a hospital, it's more like 30% of those survive. If you need cardiac arrest because you've been bleeding massively from an automobile accident or a gunshot wound, those people who bleed and go into cardiac arrest, it's called exsanguination cardiac arrest, less than 5% of those people survive because they've bled out at the scene, so to speak. They can't be resuscitated. Their brains aren't getting enough oxygen, you know, for a period of time. And if good CPR could be done for a while, and then they can be quickly receive EPR, they have a better chance of survival.
No, I completely understand.
And the initial clinical trial is really being done on trauma victims. At Maryland Shock Trauma, they bring in, you know, by helicopter ambulance, all the trauma victims, really the serious trauma victims in the Maryland, Washington, D.C., Virginia, Delaware area, that tri-state area. Maryland Shock Trauma is sort of a model facility for serious trauma victims. A helicopter can come in, land on the roof of the building, the elevator doors open, and one level down, you're in a trauma bay with surgeons. You know, it's faster than any place once you get to the trauma center. And so, you know, EPR is a dramatic step forward. It's a revolutionary advance. Every advance in medicine, there's the initial period, it gets refined, improvement becomes all more automated. So this is sort of the first step. Maybe you could say CPR was the first step. Now EPR is the second step. And, you know, ultimately, I mentioned, you know, additional drugs for cooling. You know, during the cooling phase, there's certain neuroprotectants that could be put in the solution to help protect the brain even more. It's like these neuroprotectants, a lot are studied just to help people with a stroke.
Mm-hmm.
And so there are a number of things that could be used while cooling the patient down or before cooling the patient during CPR that could be beneficial. So
Yeah, to
those will
protect.
all be tested over time. The equipment will be, affordable, and the goal is to save lives. In one sense, dedicated to the memory of Peter Safar, the father of CPR, and really the father of EPR as well. And at the University of Pittsburgh, he was in charge of the Peter Safar when he was alive. It was the International Center for Resuscitation Research. And now, when he became professor emeritus, they renamed it the Safar Center for Resuscitation Research. But he's trained fellows from all over the world would come to the Safar Center to work with Peter Safar. Yeah, fellows are now all over the world. In fact, the Freedom House that I mentioned before, the first paramedics, the fellow that was working under Dr. Safar at the time, her name was Nancy Caroline, and she went to Israel to train and start Israel's paramedic service. Mm-hmm. And in Israel, she's considered the mother of paramedics. It's sort of amusing. So Dr. Safar's reach has been around the world. He was nominated for the Nobel Prize, I think 3 times.
Wow.
He didn't receive it because they like giving the Nobel Prize, in a sense, for more basic research, not for clinically successful things, if you look at what the Nobel Prize is given for. But still, he was nominated 3 times. He was.
I just wanted to mention we have 7 minutes, so I have some. Actually, would love to have you on the podcast again, just to maybe go further on into detail. But then I do have some questions actually in relation to. Well, actually, you just mentioned it. You already touched on the status and the rollout of EPR. You mentioned the clinical trials are in place, and I was going to ask how you said 2024. The outlook is maybe 24 is when we're looking at implementation. But then along with that, I was going to ask, 2 main questions were, the first one is, what is your vision for EPR moving forward? How would you like to see it, not just in the state of America itself, but globally? How would you envision it being used? And secondly, how would you feel about the current healthcare systems in place right now in handling trauma victims? How effective do you feel that they are? I know it's quite a broad question, but considering EPR is actually meant to supplement and aid trauma victims in their likelihood of survival, how do you feel about the state in which trauma victims are handled in today's world with the technology that we have currently?
Well, trauma victims, depending on the severity of the trauma, are not handled well. Now in the U.S., I think the biggest reason for the death of individuals, children under the age of 18, is gunshot wound. Mm-hmm. I mean, it's because of the gun laws in the U.S. I don't want to make any political statements, mm-hmm. but young people, trauma victims from gunshot wounds, automobile accident, motorcycle accidents, is a tremendous problem. And depending on the severity of injuries and how quickly they bleed out, CPR may or may not help them. And so there's an important role for EPR in helping to save those lives. Now, the first phase, after our clinical trial is done, and I fully anticipate success, it's always difficult to predict what the FDA will say until they have, look at it in a group meeting. The FDA could say, oh, this is terrific. Any person, any surgeon trained to be involved in this can go ahead and do it. Or they may say, okay, you've done it at 1 center, let's do it at 7 centers now and get a broader evidence of how this works. So, when we originally set up the clinical trial, 7 trauma centers in the US, the best trauma centers, they all wanted to be involved, but we didn't have the money to do that because it's costly to do these studies. But I'm hoping the FDA, not a certainty, they may say, okay, you can do this at trauma centers. Let's make sure the teams at the trauma centers are trained to do this, give them some sort of certification. And as this broadens out, trauma centers, emergency rooms, we'll look to do, after the initial phase of the FDA, we'll look to see, well, how can we get paramedics to do this in the field? And the FDA, of course, will say, well, we've got to make certain they're trained and the equipment works, and there'll be some sort of field clinical trial done, so it's hard to predict. I hope in 2024, this is sort of generalized to trauma centers, and maybe in 2025 to emergency rooms, and maybe 2025 we'll get some paramedics doing it at some university medical centers. It may be 2026 before you get all paramedics involved. It's hard to predict. I'm hoping it'll go quickly, because this is about saving a life. This is not about is this drug or that drug better for psoriasis, or is this drug or that drug better for arthritis? This is about saving a life, and you have no other alternative, so to speak. So I'm hoping it'll move quickly, but it's very difficult to predict. Now, for this going around the world, obviously in very westernized, medically advanced countries, it would move quickly once the FDA approved it. There's interest from people in China, most European countries. The Yaffe Center has outreach to most European countries, obviously Japan, Canada, South Africa. I think, at least in the big cities, are certainly
100%,
medically capable of doing this.
They should be able to take it on.
I don't know. I'm not really familiar with the statistics on trauma or sudden cardiac arrest in South Africa. I assume it's somewhat similar to the U.S. I don't know specifically about gunshot wounds or laws there, but I imagine automobile accidents are, similar to the U.S. I think in the U.S., let's say we have 350 million people. In South Africa, where you have 50 to 60 million people. So maybe you have, 1/6 the number of sudden cardiac arrests every year, and certainly less trauma victims. But I think a country like South Africa is certainly capable of doing EPR. I mean, South Africa did the first heart transplant, right?
Yeah, no.
I recall why. And so it'll move around the world, first in urban centers and then more rural areas. We have interest from...
sorry, doctor, to cut you off. I just realized we're on less than a minute. So what I'm going to do is I'm going to end this recording, and then I'll start another one, and then I'll edit it into the next video. So I'll just start it short so that you can summarize. I don't want you to cut off. So yes, no, firstly, I just wanted to say thank you so much, doctor, for coming on to the show. I truly believe that this technology will revolutionize the way we treat trauma victims, especially in this new world, which is becoming very technologically astute. This is definitely going to be something that's going to be a cornerstone in that new world moving forward. So, and I actually excited to see further news and updates from you as to how the implementation is going, how the trials go. But firstly, I'd just like to hand it over to you if you have any concluding remarks of your own. But from my side, thank you so much for coming onto the show. We're obviously a small podcast, so we appreciate any guests that come on and share. I mean, I did not know that suspended animation was actually being implemented in treating people. I used to see it in movies and it was something of the fiction, but now that you've given a very practical, hands down explanation as to how it works, it's truly phenomenal. And continuing on from work that has already been established is truly, I think, what medicine is supposed to embody. And so, yeah, I just hand it over to you, doctor.
It's been a pleasure talking to you, and I'm delighted to be able to spend some time talking about EPR technologies. I think it's ultimately going to be very successful in saving lives when CPR fails, and I think it has a very bright future. I should tell listeners and viewers that if you go to the website www.epr and then a hyphen or a dash sign, technologies.com. Also www.epr-technology.com. Plural technologies are single. It'll take you to the same website, and there's a lot of history and information there. And I think podcasts and me talking to look at. So I think keep in touch with us, and you'll see the progress of EPR over time. And I think we're going to be very successful. And our efforts continue to be dedicated to Dr. Peter Safar, the father of CPR. And as all medical advances go, artificial intelligence and augmented reality are gaining traction in medicine, just as it might be gaining traction in other industries other than healthcare. And we're going to utilize that as a necessary component of what we do to make it as simple as possible for paramedics to perform EPR, rapid cooling, followed by transport surgery and delayed resuscitation. And I hope to be in touch with you all in the future. It's been delightful talking to you again, and everyone stay well.
Thank you so much, Doctor. Thank you for hopping on, and apologies the flu. We truly appreciate it, and all the best moving forward.
Take care.